Hello, everyone. My name is Zubin Chang, and I'm a resident at Kaiser Permanente Fontana Medical Center, and I will be presenting to you about a case report titled The Irony of Iatrogeny, Hydralazine-Induced Vasculitis. Special thanks to Dr. Winston Chang, Dr. Brenda Palayo, and Dr. Naveed Frutan. The aim of this presentation is to shed more light on a familiar adjunctive antihypertensive, as you may already guess based on our title, hydralazine, and its association with a rare autoimmune side effect called hydralazine-induced ANCA vasculitis and hydralazine-induced lupus syndrome. We have here a case of a 72-year-old female with a history of hypertension, coronary artery disease, diastolic heart failure, and COPD, presenting with symptoms of productive cough and a 40-pound weight loss in the past 6 months. Physical exam was positive for basal crackles bilaterally. Initial labs revealed iron deficiency anemia, improved with packed red blood cell transfusion, as well as an acute kidney injury, initially improved with IV fluid resuscitation, but relapsed with oral challenge. Imaging, as you can see here on your right, shows a coronal view of a chest CT showing diffuse bilateral ground glass opacities. EGD and colonoscopy was negative for malignancy. Autoimmune labs were ordered, as seen in this blue box here. Based on these autoimmune studies, the diagnosis of hydralazine-induced ANCA vasculitis was suspected, with the following management, starting with discontinuation of hydralazine. The patient received a pulse steroid of IV methylprednisolone for 3 days, then transitioned to oral prednisone after. The kidney biopsy the following day showed ANCA-associated vasculitis. Plasmapheresis was also initiated for 5 days, as well as hemodialysis through a tunneled catheter. She was discharged home on rituximab and hydroxychloroquine. 2 weeks after her discharge, she had severe hemoptysis and dyspnea and expired, suspected secondary to diffuse alveolar hemorrhage based on CT chest findings. As of now, there's no clear data on the incidence or prevalence of hydralazine-induced ANCA vasculitis due to its rarity and its lack of prospective studies. It is also challenging to diagnose this type of vasculitis as there's no formal criteria that exist. But there is the diagnosis of drug-induced vasculitis that can be supported by high titers of multi-antigenic ANCA, antihistones, and beta-2 glycoprotein 1 antibodies, as well as a tissue biopsy. In our case, there was initial concerns for lupus nephritis in the setting of high double-stranded DNA antibodies, as well as relatively low C3 levels. But a diagnosis of hydralazine-induced ANCA vasculitis was made based on the high myeloperoxidase antibodies, the mildly high proteinase 3 antibodies, the histone antibodies, and the beta-2 glycoprotein 1 antibodies, and also the findings of kidney biopsy showing Pol-C immune crescentic glomerulonephritis with a 50% active crescents, and patients showing clinical improvements after discontinuation of hydralazine. The exact mechanism remains unclear, but there are several risk factors that predisposes one to this type of vasculitis. This includes older age, cumulative dose of 100 grams at the time of presentation, female sex, and a history of thyroid disease. Our patient was an older woman who had been taking oral hydralazine for over 20 years before presenting with symptoms, with dose adjustments ranging from 50 milligrams to 150 milligrams per day. This type of vasculitis most commonly affects the kidneys, but can also involve other organs as well. The clinical presentation of our patient is consistent with a rare case of hydralazine-induced ANCA vasculitis with pulmonary renal syndrome. The patient presented with anemia, dyspnea, and cough with blood-tinged sputum, with possible alveolar hemorrhage on chest CT. And additionally, there was hematuria, proteinuria, elevated serum creatinine levels, and a kidney biopsy confirming glomerulonephritis. Management requires immediate withdrawal of hydralazine, which should be listed as an allergy and closed off from future use, and if indicated, initiation of immunosuppressive therapy. In our patient, hydralazine was discontinued on hospital day 8 with initiation of pulse steroids and addition of rituxan, plaquenil, plasmapheresis, and hemodialysis over the next few days. There was rapid improvements in their kidney function, and the patient was medically and hemodynamically stable for discharge home. Unfortunately, the patient had passed 2 weeks after discharge from the suspected diffuse alveolar hemorrhage, likely as a result of the hydralazine-induced vasculitis. Our case study highlights the importance of recognizing individuals at risk for hydralazine-induced ANCA vasculitis due to its rapidly progressing and highly lethal nature, as demonstrated in our patient. Though this type of vasculitis is a rare occurrence, we recommend that practitioners proceed with caution when prescribing long-term use of hydralazine. We thank you for listening to our presentation, and we hope that this case will serve as a foundation for the development of a criteria for the use and monitoring of a potentially fatal flaw of a widely used medication. On the lower right, we have our references here. Thank you.